button to turn it on.
Hi, I'm Wayne Jurecki, Vice President at Bell Ambulance in Milwaukee.
So thank you to the panel. How this can, all public and private. And all those services, they could always be otherwise. So with that, I will. Yes.
Great. Thank you very much, Representative Lauenbeck, and thank you all. And thank you for having us come here to Madison and visit with you and share this program with you. As Representative said, my name is Matt Onstadt. I work for a company called Sellers Dorsey. We do Medicaid financing work with states, with healthcare providers, with ambulance services providers, and we're working here with the Professional Ambulance Association of Wisconsin. We do these kinds of programs across the country, and so we're here to tell you a little bit about how these programs work. Oh, I get to change the thing. Okay. How these programs work, and then we'll be fairly brief. Some of the information, most of the information's in the memo that you have, and so we'll be fairly brief up here, and then just stand for questions too.
Wonderful. Thank you, Matt, and thank you all for attending today. Healthcare financing programs are widely used to support Medicaid across the country. At present, 49 states and DC have some kind of financing initiative, with about a dozen states supporting an ambulance-specific program. Other states have begun using CMS-approved supplemental payment programs for both public and private EMS services to support higher rates without using GPR funds. But at present, there are no comparable financing mechanisms for EMS providers in the state of Wisconsin.
This program, what's in the bill, has programs for both the public and the private ambulance services providers or EMS providers. And we're going to talk about both of those. For private ambulance providers, for private providers in general, let me take a step back. All programs in Medicaid, the state has to have a source of state share, state dollars that can be put towards the Medicaid program to pay service providers, and that is then matched with the federal Medicaid dollars. So private providers don't have a source of state share. They don't get appropriations or have access to state and local tax money. So using an assessment is a way for private providers to generate that state share that can then go to the state, go to DHS, the state agency for Medicaid, and then they make payments back to the providers and pull in the federal Medicaid dollars. And we've got a little flow chart that'll show you how that works. And again, answer any more technical questions that you might have. These programs are widely used, 100% legal. They're in the rules, the statutes, and the regulations for the federal Medicaid program. But there are some rules about it. The assessments must be broad-based, meaning that all providers of those services have to be part of it, have to pay the assessment, and they have to be uniform in that they all have to pay the same rate. And the maximum of that rate is 6%. It could be less, but it can't be more. But all the providers, one can't pay 3 and 1 4 and 1 5. They would all pay the same rate, whatever that rate would be, up to 6%. So again, we'll get to that flow chart, which I think was also in the memo, and that explains it a little bit too. But I'll let Alexa take this one.
Thank you. As mentioned previously, healthcare financing programs are widely used across the country, with the majority of states you can see in the darkest blue-green color up on the screen. A majority of states are supporting 3 or more healthcare financing initiatives, including the state of Wisconsin, which does have a few programs at present.
Yeah, so Wisconsin has an assessment program, if you will, for providers, for hospitals, nursing homes, and I believe the third one is the intermediate care facility. So it's used all over the place, every state except Alaska, and it's currently used here in the state as well.
Wonderful. This diagram that you can see on the screen, which was in the memo that you all received, it illustrates how dollars from private ambulance providers go to the state and then to DHS, which is the operating Medicaid agency, which then makes those Medicaid payments that include both the state and the federal share.
So that's the private EMS services. The private providers will use this vehicle, an assessment, a provider assessment that we just explained. For public providers, there are a couple different things they can do. As I said, they have access to state share because they are public. So they have either appropriations or county money or local money, what have you. They have the state share. They don't need the assessment to do that. What public providers often use is something called a certified public expenditure model or an intergovernmental transfer model. And the bill includes language about a certified public expenditure or CPE model. So briefly, and at a high level, the way this works is providers are their cost for providing Medicaid services is typically higher than what Medicaid reimburses them for those services. And so under a certified public expenditure program, the providers will demonstrate, they will certify to the state agency, to DHS, that their cost for delivering these services was here and their reimbursement was here. The part that's left over that they didn't get reimbursed for, those unreimbursed costs, is eligible to receive that federal match. So for example, if their costs were $1 million and they received reimbursement from the Medicaid program for their claims of $500,000, they would have $500,000 unreimbursed. And that can get matched at the rate, which here in Wisconsin is about 60% federal. That can pull in that 60% federal. So 60% of 500,000, whatever that is, I think that's 300,000. So that's how this program works. And we have a little diagram for this one as well. Again, this just explains that the money is not being sent to the state like it is in the assessment, but rather the providers demonstrate to the state and certify that their costs were here and their reimbursement was here, and the leftover amount, the state then can go to the federal government, to the Centers for Medicare and Medicaid Services, and say, give us that 60% federal match for these unreimbursed costs. And again, in the little explanation I made, with 300,000 out of the 500,000. So either way, in both the private and the public side, there would be supplemental payments. There'd be payments made. The rates themselves don't have to go up, but effectively they do, because there are supplemental payments made to these ambulance services providers from DHS that either because of the state share that was generated through the assessment or through the certification of the public expenditures. And then supplemental payments come back so that additional funds can be provided to improve services and for all the reasons that the representative mentioned. So that's our presentation. I'd like, if there are any questions, we can answer them, but I'd like to give Chris a chance to talk from the ambulance services provider's perspective.
Yeah, thank you, Matt. Just a couple of points for clarification for everyone. Number one, there's no cost to the state, and obviously that's an important point. Number two, the private side assessment is mandatory. However, the public CPE program is optional. So if there's a fire department, for example, in a part of the state that just does not see a lot of Medicaid, and this wouldn't really benefit them, perhaps it's not worth their time or effort to certify their costs, they don't have to participate, and there's no harm to them in not participating. But in more of the urban areas, obviously it is worth their while, and most medium-sized or larger cities already do some form of accounting that would easily qualify for what we're looking for here. So it's not a huge burden on the municipal departments. I think just, my opinion, the most important thing, the most important reason I think that we need to fix reimbursement is so we can take and make emergency medical services on par with other healthcare providers. Obviously nurses do a spectacular job, and we just cannot pay our providers the same. And, it's causing us to lose interest in our industry, which we can't afford to do right now, less so than any time in history. We want to attract new people to the industry. And, obviously people want to make a good wage. So really that's the number one. We all struggle with issues, the biggest being staffing. So if this can help a smaller service, go from paid on call to fully paid, that would be excellent. Just one of those examples would make this program worth it. So that's just my own opinion, but I'm happy to answer any questions that you might have, as well as our friends here.
Thank you. Chris covered most everything that I would have from the provider perspective. This is something that while Chris did mention that it would be a mandatory assessment to the private providers, this would be beneficial, particularly in areas where there is high density with Medicaid. but that applies anywhere in the state. So this is a way to get the federal matching funds without having to use state funds to do that. So honestly, I'm here more for the question aspect. Thank you.
Thank you, Wayne. Again, my name is Jerry Biggert. I've been the EMS board chair for 3 governors and have listened to the stakeholders around the state and the service directors around the state increasingly turn to us with big questions, and we don't have a lot of answers for them. And they largely relate to money and the recruitment and retention of personnel. And those things come together. I feel like I'm feeding back. Sorry. So a couple of things, we're at a point right now in EMS where every dollar hurts and every dollar helps. So even if an area may not have a massive amount of Medicaid patients, if that brings in an extra $20,000 a year to some of those communities, that would be a ton of money in EMS. That's how underfunded EMS is in a lot of places in the state municipally. This in 2022 will be the first time Medicaid rates have been adjusted and increased in the state of Wisconsin in over a decade. So for the last 10 years, we've been conducting business at the exact same amount of revenue as we were 10 years ago or more, as costs have increased. That has put us in a kind of a dark place because we've had to adjust for all of that for over a decade. And we're not easily able to pull ourselves out of that hole that we're in. This would help us do that. Like they had stated, there's no one thing or magic wand that we can wave over EMS right now, but this would be one of the most substantial things that could possibly happen for EMS in Wisconsin. We have ambulances in cities, and those are city miles with 100,000+ miles on them. And those are the ambulances coming to pick people up that are in life-threatening condition. No ambulance should have 100,000 miles on it as a primary ambulance, picking up somebody that needs to get to a cardiac cath hospital or a trauma center. But we have no choice because there's no money. The inability to progress with new technology, be it different equipment that we can use to protect backs or to do better CPR on people or to better control their bleeding or better control their pain by increasing the level of care the service provides. We can't do that because there's no money to support it. We can't educate the people. We can't get them to school because we can't pay them, and we can't even pay for their classes in a lot of instances. The equipment that goes up and the expectation of the community continues to increase and rise. We can't make that up. So cities have to decide, are we going to buy this new equipment that increases people's chance of survival? And if we do, how are we going to pay for it? Where is it going to come from? Communities that people think are doing great can only raise their taxes next year less than 0.75%. That's not a lot when you have to lay down new roads. And so for the money to come back to EMS or to be credited to EMS, we need to explore every single option we have. And this is the biggest option we have yet to explore and make happen. Our call volume in my city has gone up 40%. We have not added one single piece of apparatus. And we have no hospitals in our city. In Oak Creek, in Milwaukee County, we have 0 hospitals, 29 square miles. We're bordered by a lake. We have to go to other people's communities to take patients to the hospital. Our rigs are out of service all of the time, and we just don't have any people to be there to back those rigs up when they're out of the city. So then we have to call another city that's already taxed. We can't even afford to handle our day-to-day operations. This money would help us drastically. In cities around us, like Racine, we're talking about at least $1 million a year more coming into that city credited to EMS. And that's based off of numbers from a year ago. Seems like everybody's call volume and acuity of their calls has gone up. You know, the rural areas, this, if they combine their resources, this could get them over the hump to get 1 or 2 people, even if they're just in SUVs, to first respond, to stop that clock. We don't have a lot of science in EMS because it's a lot of anecdotal evidence, but we know that if somebody doesn't get to someone whose heart stopped in 4 minutes and 59 seconds, that person's going to start suffering brain damage. We need to be able to have people on the road that can first respond and deal with these time critical calls and interventions. And there's no way to do it without money because people just aren't volunteering like they were back in the day. That's over. And we just need to look at options like this that could bring so much money that could be credited to EMS into the state of Wisconsin. And I'll stop because you know I can keep going.
I obviously we brought Jerry along for a reason because he's passionate, but he's 100% correct. No question. And I just have to reiterate again, no cost to the state. So I think that's our biggest takeaway here. Besides the obvious benefits, I mean, no cost to the state is huge.
Can we go back and like walk through that whole chart?
Sure. We'll start with the private one. You want to do that one again?
Sure, I'm happy to. Okay, perfect. So it's up on the screen. So we can go a little bit more step by step into what's outlined here. So EMS providers would pay into that assessment to the state. So it would be a certain percentage for each provider. For example, at the end of each quarter at a rate that is set before it is put into place. Step 2 was that funds will go to, so from the providers via the.
Can I interrupt?
Yeah.
Just the bill does include I said the rate could be up to 6%, and I believe the wording in the bill is not to be less than 1/4 below the federal maximum, which would be somewhere between 5.75 and 6. So that would be the rate, and what that rate is applied to for the assessment is net patient revenue from the providers.
Thank you. Step 2 is the funds collected via that assessment go to the state Medicaid agency. So the operating Medicaid agency in the state, which would increase the reimbursement to the EMS providers. And then those funds would go and be matched via the federal government. Matching funds, we had mentioned earlier, the federal rate, which in the state of Wisconsin is about 60%. So those funds will then be matched. It will go back through Medicaid managed care. So the MCOs and the HMOs, which you have here in Wisconsin, would receive payment using state and federal funds. And then those payments would be made back to the EMS providers. So they would receive the supplemental payments directly and fee for service.
The state funds are generated, the state share comes from the assessment itself. So if all of the private ambulance services providers pay that 6% of their net patient revenue, that will generate an amount of money. 8 or 9 million, I think, is what we've estimated. So $8 or $9 million is generated to be the state share. When DHS makes the supplemental payments back to those providers, they're paying that state share back, that 8 million, and they bring in the federal dollars of, I might have the numbers wrong. I think we calculated to be about a $20 million federal gain. So I don't have those numbers down here, but that's what's coming back. So it's not coming from GPR. It's coming from this, the state share is generated by the assessment, and that amount of dollars then is paid back. And when it gets paid, it brings in the federal dollars of about 20 million, I think is the estimate for the federal portion.
And then, it goes back to the people who provided the initial money. They get that share back in the same percentages, basically.
No, it's all payers. It's actually, that's another rule I didn't mention, is you can't only put the assessment on the Medicaid expenditures. So it's revenue from commercial, Medicare, Medicaid, self-pay, whatever their revenue is. You can do different things. You can, leave out Medicare if you wanted, but to create the biggest pie, you would do it on all payers, commercial, Medicare, Medicaid, and self-pay, and any other payments you might have. Correct. This would not this is not passed down to the patients that are using the services. And it's not, again, as I mentioned, that this is not specifically changing DHS's fee schedule. These would be supplemental payments that would come quarterly in a lump sum back based on that. And the way these programs work, and we do have, as that one slide showed, about a dozen programs like this across the country, and many more for other types of providers, but for ambulances, about a dozen, is that assessment gets paid by the providers, and DHS makes the payment based on their Medicaid volume with a very little turnaround, so the providers aren't floating their those costs. So it's.
So I represent a very rural. So this program is where you don't have a lot of medications, you can look at it quite a much back where
Yes, but I mean, in all the places that we've been working, those that are underwater, those that have very little Medicaid, and they're paying on all their payers, commercial, Medicare, Medicaid, and only getting back based on Medicaid, because Medicaid is where that federal match comes from. So there could be situations where you would pay in more in the assessment than you get back. But we find that to be very, very rare, particularly in places like you're talking about, where there's a lot of Medicaid. That level of Medicaid doesn't have to be too particularly high to get you over that line to make you gain from this program. And the association will do what they can. If there are providers that end up underwater under this program, the association will work with them to ensure that they see a benefit from it as well.
So Bell Ambulance pays this matching assessment. However, Oak Creek would be part of this certified public expenditure, which is technically what's currently occurring right now. Bell Ambulance may not receive that much, but Oak Creek still receives that because they use the fund as it is right now. So by Bell putting that assessment fee in, it allows for them to be able to include that additional reimbursement to the federal match. Am I speaking correctly?
Correct.
Yeah.
Maybe I should show this other one too, the public one. Yeah, there's. Yeah, it.
So this example here is pretty much what's happening currently with public EMS plans. So we receive things like that, but you as well may not receive as much reimbursement to provide the services to Medicaid patients because you are a private entity where the federal dollars aren't fully taxed when it comes to that.
Right.
No, but neither of these programs are actually happening right now, neither the private
Right.
program or the public program. So the public providers, when either if you're delivering an ambulance service, advanced life support emergency service, you will submit that claim to the Medicaid program and they'll both get the same reimbursement, the publics and the privates. Correct me if I'm wrong there. So they're not getting any, these supplemental payments are not happening on the public side nor on the private side. And the way that the public model works is that for Jerry's company, he's receiving back $300 for that claim he submitted, but the cost to deliver that service may have been $600, and he's only getting $300 from Medicaid. So that difference is, right now, he's not getting anything for that. It's, his dollars that are paying that extra 300, which happen to be state dollars because he's a public provider. So under this program, he would certify to DHS his costs of 600, and they know that they've reimbursed him 300. So he's got that extra $300 for that claim. And then you add all those up together for Medicaid. And then you can draw on the federal dollars to cover the federal portion of that unreimbursed cost. Does that make sense?
Well, I guess what I'm trying to understand, are you federal, or am I missing something when it comes to the EMS reimbursement rate currently that
Well, what that they're paying, oh, sorry, go ahead.
That's what I'm trying to get. Currently, DHS is theoretically supposed to be having the state portion. And reimbursement rates have not significantly increased with inflation and everything else. And so I guess where I'm trying to understand is that additional gap that I'm missing on the federal graph.
So I think I can say, are we not, or EMS not receiving any federal funds right now?
No, the payments, use that $300 example again. So that payment for that advanced life support transport does include, the $300 does include 60% of that is federal. So they are for all services, whether they be ambulance services or hospital services or any kind of service that's under Medicaid is pulling in that 60% federal dollars now. The difference is by demonstrating additional state dollars, either through the certification or through the assessment, you can pull in additional federal dollars. But the claims that they're getting paid now do include both the state and the federal, for both public and private.
But you're saying like hospitals right now are capped.
Correct.
They're not allowed.
And correct. Hospitals are, and hospitals, I think, do add a fee to the patient bill for this purpose. We're not doing that. This will be completely covered by existing revenues in the industry. We're not passing anything on to patients. Quite honestly, even if we did, nobody would pay it. So there's no point in doing that. So this is a way to increase the federal match without increasing the state match with state GPR dollars. It's a way to, I don't want to say make it up because it's real, but it's just a way to get more federal money without the state having to raise its rates. We're trying not to do that, but Mhm.
It's decreasing it only long enough for the funds to go to DHS, receive the match funds from the federal government, and return more to the provider. So it is a movement of funds so that the assessment that we as a private entity pay gets paid back to us along with the federal matching funds. It's a way to draw down more federal funds without increasing GPR beyond what's in the budget currently.
These are all some of the questions. That's what I asked. So I wasn't here. But they're charging that all that's in everything on, and then they draw it out. program will say, they're gonna take up to 6% of their own revenue. Put it out there, get the match, and the back. So, no impact on the taxpayer or the state, but we have to pass legislation in order to let that federal match go. But the risk is really, I mean, we're enabling this to happen, the risk is really on the driver. Question about, you know, are there dealers and movers? Probably, but overall, because because everybody is moving on under the current program. So the way that the program is designed to work, if you want to put in more state dollars, you can.
Sure.
You have to short hospital to put GPR that help them. This is different from that. But it's taking advantage of these little pieces of federal matches that we're not.
Right.
And then how to follow.
There may be a provider that takes a loan to make their 6% payment, knowing that it's worth it to get that federal match back. So, you know, that may very well happen. Our biggest expense by far in EMS is wages, and everyone's intention is to take this money and put it all into wages. Really, I think that's the key for our future. It has to be. We can't just keep doing what we're doing. So.
Like, let's say, oh, we did this. Put the money. The money we are.
I believe it would go to the general fund, but all department heads face that, whether it's the police and, you know, the money that they gain through citations, or we gain through EMS transports, or the building and, you know, folks get through plan reviews, but you're credited for it. And when we can show that we are, you know, getting closer to we're not getting redder, that helps. I mean, even this doesn't put us anywhere near the green. It drastically helps though, because when you look at the other states that have done this and what they've been able to do with that money, and who knows how every single municipality is gonna view this. But there's no doubt that it gives the fire chief or the EMS director the ability to get up there and say, you know, through our work and through great legislators, we've been able to double our Medicaid funds. Now we've opened up this match with Medicaid. And in a lot of communities, I just think people underestimate the amount of Medicaid folks that are outside of the population centers in the state.
17% of the entire state.
So it's, you know, when I talk to services up in Waushara County, I mean, it's stunning to me, like how many people are on Medicaid there. You just don't think of like rural areas being Medicaid areas, but it is. And a lot of people are utilizing those services. So I think they have already said it. This isn't mandated for public providers. It's totally up to each individual public provider if they want to get involved in this match or not. But when you start running the numbers and realizing how much extra money this is for largely documentation that you should already be tracking if you're getting Medicaid or Medicare dollars, it really is a win. To me, on the public side, there's just winners and winners, because either you just don't do it because you don't see the value, or you're going to get more money. For documentation you're largely already doing, should you ever be audited by Medicare or Medicaid people for what you're charging for now. Now fix what I said if I said something wrong.
No, that's absolutely right. I mean, there's one clarification. I mean, you've included language in the bill that does say these dollars need to go back, at least on the private side, need to go back to for EMS services and not be taken for other purposes. So I mean, that's a safeguard as well.
Will this also, will this not only emergency services, but also be able to provide or not?
It can, and we are hopeful that it would be used for both. And I think the bill also includes language about that, defining the services that would be included here as both the emergency services and the interfacility transports. And so covering all the services that these people deliver. And again, we in those dozen or so other states that are doing this, there are a couple of states that have limited the codes, you know, to the emergency codes that I think 2 or 3 states have, and the others are including both. And both programs have been approved by the federal government and are operational.
I just wanted to add here that at least from the Bell Ambulance perspective, this is something that we are eager to go ahead with because we see this as a way to increase the revenue that we have to pour back into our staff for retention and recruitment, so that this can go back to our staff that we have in southeastern Wisconsin, since that's our operational area. But I see this would work for any of the private entities around the state to be able to get more funds. And many of them that we talk to see this as a way to retain employees or even recruit additional staff that are short-staffed. So this is helping us immensely, or will help us immensely, with a lot of our workforce things, to be able to draw more people into this industry rather than having them go to unrelated fields if they already are an EMT or paramedic, or even to get people interested into it with a fair and more comparable wage to other industries.
It's something that's surprising to a lot of people is less than half of the new EMTs in Wisconsin actually end up working on an ambulance. So that's one of the things we're hoping to change. You know, we have competitors for workforce from places we never dreamed of before, like Amazon, with these massive warehouses who hire EMTs to handle, you know, workplace injuries, things like that. Hospitals are realizing the value of our people, and they're cheaper than nurses, which is what we're trying to fix. So they're hiring them in hospital settings. So we're trying to get people back to the root of EMS and to be available for the communities.
And while the bill has 2 distinct components to it, the assessment is for the private non-government, let me rephrase that, the non-governmental. So that could be a private organization such as Bell, that could be other nonprofit organizations that may be hospital-based or other entities. So that's all on the assessment side. So nonprofits are included in there. Then the municipal side are people like Jerry that are municipal-based. So this will have an aspect that covers all EMS providers throughout the state. This is not leaving anyone out through one side or the other. It's a source of additional funds.
Right.
Unfortunately, if you're not an agency that currently bills Medicaid for your services,
And also this type of program, the assessment program, at least, not talking about the municipal program, I think we could talk about that separately, but the assessment in federal law and statute, and there are 19 different types of providers that can do this program, do an assessment program. Ambulance services is one of them. Other types of first responders are not listed in that federal law. And again, if you're not billing Medicaid, there'd be no.
yeah.
I think the one thing that I'll add, after, I mean, I did like a 1 hour, pretty much 1 hour listening session with EMRs last week. And they all work with transporting agencies, and through some working together and synergy and opening people's minds between the increases that are coming through Medicaid already, and hopefully this plan and money that goes into the grant, what is it? FAP, thank you, the Federal Assistance Program or Funding Assistance Program. Hopefully that trickles down to the EMRs that are supporting those transporting agencies, because the EMRs are the people that stop the clock. We are in a terrible spot without those folks, especially in the areas waiting 25 to 30 minutes for an ambulance. So we desperately need to show the value of the EMR. And, you know, we definitely do that on the EMS board side. And hopefully the more money we can get into EMS and the transporting agencies, the more support they can give the EMRs, be it training or equipment reimbursement, things of that nature. That's a great question. After last week, I'm blown away. I mean, I talked with Danielle shortly after that meeting, just shaking my head about the EMR situation in our state. Mortifying.
Yeah. Wayne mentioned various types of private providers. Some of you are familiar with some of the larger nonprofits such as Gold Cross or Gunderson, and hospital-based as well. There are a lot more hospital-based ambulance services, particularly in rural Wisconsin, than even I realized. So there are a lot of potential winners. And that goes back to what Matt said earlier, that the potential for people to be not helped by this or to even be harmed by it is pretty remote.
You guys are available if people want
Absolutely.
to follow up or look at their, I know that you guys talked to the town association about it.
Yep.
Do we now?
Yes. Yes, I believe so.
Like we're trying to go at
Yep.
so that's also-
It is. It is. We,
the opportunity to ask questions with Mark.
we've been working on it for a couple of years. We just wanted to make sure that we were in a good place before we got to this point. But yeah, we'll be around all day.
And after today as well. I mean.
Yeah, of course.
As I offered, I mean, if you need to talk to us.
Of course. Yeah, and we can do, I mean, we'll do a one-on-one with a legislator. We're happy to do that anytime.
Any other questions?
Thank you.
Thank you.
Thank you.